Hello. Hi, Elliot Fishman here, and welcome to our latest weekly podcast. And I'm speaking to you. Where am I? I'm in a hotel room. You can see some fancy graphics on the wall there. I'm in Santa Clara, California. Santa Clara is about 40 minutes or so beneath San Francisco International Airport, so it's a little bit south. It's in within minutes of Mountain View, which is Google, minutes of Cupertino, which is Apple. Um, it's minutes from Facebook. It's minutes from the Computer Museum. But most importantly, it's 1.1 miles. I'm at the Marriott, so I get Marriott points. So let me just call out the Marriott or something like that. I'm 1.2 miles from Nvidia Voyager, the ultimate headquarters of the greatest company in the world, Nvidia. And today, some of you will be there remotely. I'm interviewing with Jensen Huang, CEO of Nvidia, the company that has invented and controls the world of AI in a very positive way. I'm sure you've read a lot and heard a lot. Well, it's been years, but surely in the last 24 hours. And tonight, I'm joining Jensen Huang to interview Ed Catmull. Ed's a name I'm sure you also know. Ed was the co-founder and CEO of Pixar for 33 years. He was the president of Disney Animation Studios, an incredible computer scientist, basically changed the world and continues to change the world. And tonight, 3:30 to 5 o'clock, will be live and in person from NVIDIA headquarters. So it's something that's just really exciting. Now, I wish I could share the Zoom link with all of you. If you're a member of Hopkins, you got the link in the mail, but I'm not able to share it with you. Maybe someday, I can't be certain, it'll be on YouTube, or an edited version will be on YouTube, but we'll be discussing the visions and plans and thoughts of two of the most important people that have truly changed all of our lives for the past 60 years. And the work they're doing today will affect the lives of your children and grandchildren and great-grandchildren. So it's very exciting, and I'm trying not to be too over the top. I have my notes here. I'm not a big person on notes, but you can see I have them. I was going to use a few PowerPoints at the introduction, but I was told that the room I'm in, which will seat 2,000 people, does not have a good setup. It's mainly meant for a live presentation, which we will be, the three of us, on stage, in person, Santa Clara. Be there or be square. Anyway, that's enough for today. Anyway, okay, let me just tell you a little bit about the bladder. The bladder is one of those organs that probably doesn't get the respect it deserves. It's the Rodney Dangerfield of organs, right? Because you talk about in the GU tract, you say the kidneys, okay, kidneys rule. You talk about the adrenal. Well, adrenals are very important. We've given many talks about that. You talk a bit about the ureter, but the ureter is a little tiny string, and yes, you get tumor involvement, you get obstruction, you get stones. And at the bottom, it's the bladder. The male has it, the female has it. We don't talk about bladder size, we don't talk about bladder volume. And at the end of the day, the most common pathology you speak about is bladder cancer. Because, bladder cancer is not uncommon. It's one of the treatable cancers, surely if detected early. There's new chemotherapy, there's obviously surgery. With bladder cancer, there are a few things that will predispose you to bladder cancer, certain exposure to certain elements perhaps, chronic infection. We also talk about the bladder in a range of pathologies. So trauma. Whenever you do trauma, you want to look at the bladder, right? Because particularly in patients with pelvic fractures, bladder injury is a possibility. Now, a challenge with looking at the bladder, If the bladder is not distended, then you can overlook pathology. In non-traumatic cases, just routine abdomens, if the bladder is not distended, you often see people read bladder wall thickening, possible cystitis versus non-distended bladder. So it's a little bit tricky with the bladder when it's not distended. So here's the things you can think about. If we talk about bladder cancer, we've mentioned before that one of the great misses is bladder cancer. In terms of the fact that bladder cancers are small, often vascular, 90 to 100 Hounsfield units, and it stands out well against urine. The thing is, they're often 1 centimeter or less, or can be a bit bigger, and so incidental detection of bladder cancer is possible, and particularly in older patients, you're doing a TAVR study, you're doing roulette aortic dissection, whatever you're doing, take a look at the bladder, okay? I think I'm trying not to overcall things, but if you see a small enhancing lesion, it's a bladder cancer, easily treated and you're making a great diagnosis. It's very easy to miss it. So look always at the bladder. What about more dedicated studies? One of the challenges is fistulas to the bladder. Two most common things for fistula are diverticulitis and then Crohn's disease, and then you can get colon cancer involving the bladder, or even a bladder cancer involving the colon. Diverticulitis is the most common cause of colovesical fistula. Now, you need to see a communication. So 2 ways of doing it. We used to give rectal contrast. That's not a bad way. And then you hope to opacify any tract between the colon and the bladder. So you would not want to give rectal contrast plus IV contrast, one or the other. A better way perhaps of doing it is to put a Foley catheter in the bladder and then under gravity drip 500 cc's of contrast. So what you do is you add about 30 cc's of Omni 350 into 500 cc's of saline and you drip it in. And then you can really get the bladder distended, and if there is a fistulous tract, you can see it well. This technique of filling the bladder under gravity is great because if you just push contrast in the bladder, if you had a perforation, you could really make things worse. Under gravity, it's going to stop if it has increased pressure, so it works out very nicely. The same thing is true in trauma. If you're worrying about bladder injury and you look only at the bladder, even if it has some distension, you could undercall the presence of bladder trauma. Bladder trauma is most common when there's pelvic trauma, particularly of the symphysis pubis or acetabulum. Sometimes you'll see a pelvic hematoma, prevesical space, or laterally, but still you may not have, and if it was there, you may not see a bladder injury. So if you're worrying about bladder injury, do a CT cystogram. Again, drip the contrast under gravity, and you should do very well. That's a very nice way of looking for fistula. It's a way of looking for bladder injury. It's a good way of looking at the bladder in general. As I mentioned, always look at the bladder, particularly when you're doing arterial phase studies. Look for small lesions, particularly in older patients. You're truly not going to pick up bladder cancer in a 30-year-old. It's more like a 70-year-old. So look carefully. Don't miss a bladder cancer that's easily treatable. Now, again, one of the challenges I do have when I check cases in the morning, overnight, is the residents tend to overcall bladder wall thickening. And the problem is, bladder measures a few millimeters normally, but if it's not distended, it looks thickened. But it's hard to say because if you looked at one set of images, is this bladder wall thickening or is it lack of bladder distension? Unless I see some abnormal enhancement and real asymmetric thickening, I tend to say bladder is not well distended. The wall appears thickened perhaps, but likely it's due to lack of distension. If the patient does have symptoms, if the patient has hematuria, if the patients have symptoms perhaps of infection, then you may need to repeat the study with the bladder better distended. But I don't want to be chasing a lot of people around, evaluating them for bladder infection when that's clearly not in the clinical scenario. Again, of course, it's easy enough to look at a bladder culture, urine culture, but again, I think we tend to overcall the suspicion of bladder pathology. So I would recommend you try to minimize that problem. So that's a good solution there. What else can I tell you about bladder injuries? There are other things in terms of bladder injuries. You want to also look at the kidneys, look at the ureter. You can have renal injury as well as bladder injury. So, of course, bladder, you're not looking at the bladder in and of itself. The CT cystogram will look at the bladder, obviously, but you'll look at the kidneys as well. So, all of it put together. Now, if you want to see a lot more cases, go to CTisus. Under GU section, we have a lot of bladder pathology. We have cancers, we have infection, we have fistulae, we have trauma, we have all sorts of pathology. Everything you would want to see, but are afraid to ask. And I am working on some new lectures, not today, however, but I am currently working on some new lectures, and one of them will be CT of the bladder, everything you wanted to know. So with that, I hope everybody has a great day. It's the 23rd of May, 2024. And hopefully next week when I'm back at work, I could tell you a little bit about today if you don't get to see it. I could tell you what we learned, what lessons we learned, and what lessons we can share with you. So with that, everybody, have a great day.